Okay. Yeah. Hello, everyone. Nice to meet you all. First of all, we are going to explain how to approach a case of station 5 or the skeleton or scheme of station 5 first. We have to be aware that basis exam is an exam of acting. It's not how much knowledge you have. It's not about how much information you know. It's about how you act as a good doctor and show yourself and impress the examiner. So you have to practice a lot how to pass the exam. Reading a lot will not help you actually, but practicing a lot will be the cornerstone to pass cases. So first of all, so our session today will be interactive simulated session of the exam. One of the candidates will come and we are going to present a case together. Uh, Same case of the exam station 5, chest pain. But first of all, we have to know how to approach what the skeleton of station 5 in exam, which is a brief consultation. Station 5, like you see, it's two cases. Every case is 10 minutes. 8 minutes will be with the candidate, sorry, with the patient or the surrogate, and 2 minutes will be with the examiner to ask you about the case, your clinical finding and investigation and diagnosis. So let's start from the beginning. Okay, before every case, you will be given 5 minutes to read the scenarios of every case, most cases before going inside. And you have to be that's right, like that. And you have to be very careful when you're reading the case about the information of the patient, the name of the patient, the age, the comorbidities of the patient, and your rule of the in the exam. These 5 minutes are very important to focus and to know all the information provided to you, because every tiny information is provided in the exam means something. It will decrease the differential diagnosis. If you are given a drug history, for example, this drug history or any medication the patient is taking may be a culprit, and it may you might need to stop this medication later on when you have the diagnosis. So every piece of the information is important in station 5. So again, station 5 is brief consultation. You have to be organized. You have to have a brain map how to approach the case. And this is what we are going to discuss later. This is a structure of a brief consultation. Number one is introduction. You have to introduce yourself to the patient. You have to confirm the patient identity. That's why you have to memorize the name of the patient. You have to confirm agenda of meeting and take permission to start the discussion. As open question, for example, in the beginning, can you tell me more about your condition? This is introduction of the station 5, of number one of the skeleton of station 5 of the scheme. Number 2 is focus history. So station 5 is composed of number 1 introduction, number 2 is focus history, number 3 is focus examination, number 5 is replying the patient concern, and at the end is discussion between you and the examiner. So we finished. Number 1 is introduction. Number 2 is the focused history. Focused history should be about, number 1, analysis of the complaint. You have to do good analysis of the complaint in terms of onset, course, duration, progression, precipitating factor, and relieving factor. Number 2, to ask about symptoms of your differential diagnosis list. If you bought 7 or 8 differential diagnoses for the case, you have to ask for every symptom, every differential diagnosis you bought in your mind. Number 3, systemic review of the case. For example, if you have a clear case in front of you, like acromegaly, for example, acromegaly, there's no differential diagnosis for acromegaly. The case is very clear in front of you. So what he needs you to do is just to review the systemic, or to ask for the systemic symptoms of acromegaly, not the differential diagnosis. But there are some cases you need to put a differential diagnosis to ask about them, like chest pain, for example, upper GI bleeding, shortness of breath. But in clear cases, just to approach the systemic review of the case, not to ask about differential diagnosis. We are going to discuss that later, but just to have a skeleton or scheme in our mind. Uh, Again, about the focus history. So in the focus history, we have to ask about number one is analysis of the complaint. Number two is symptoms of differential diagnosis or systemic review of the patient. Number three is social history. In station 5, you have to ask about social history, and we have 4 questions on social history: what the patient is doing for living, how much his symptoms affect his job and usual daily activities, and with who the patient is living at home, who is supporting the patient at home, and if the patient is financially supported, if the patient is smoking or drinking alcohol. These 4 questions are fixed for all the cases, or for the social history for all the cases. Medical history is very important to ask about any long-standing disease like diabetes, high blood pressure, ischemic heart disease, family history of similar condition or long-standing disease, drug head list of the patient, and you have to ask about in the drug history about regular medication, over-the-counter medication, or recreational drugs. This is the focused history for station 5. Don't ask irrelevant questions because you don't have time. It's just 10 minutes. So you have your question should be targeted to the point, to the analysis of the complaint, to the symptoms of differential diagnosis, to the symptoms of systemic review of the patient. In addition to that, social history, social history, family history, medical history, and drug list. After that, sorry, still. After that will be the focus examination. Focus examination, you have to examine only the signs relevant to the case. Don't do full examination, just the signs which is negative, could be negative or positive, relevant to the case. After that, replying the patient concern. This is a scenario. Let's start directly to have simulated case of the exam. So Mrs. Leonard is 42 years old. She presented to A&E with history of chest pain for the last 5 days for your kind care. So you are giving this scenario now. You have to be in your mind the differential diagnosis before going inside to see the patient, and try to be or try to think about the more often or more frequent differential diagnosis. So I need someone to start and to have this simulated exam case with me. We are going to give 10 minutes. Who's going to present the case with me? Aisha, would you like to do it? It's all right. You can come here. It's all right. You have a couple of minutes, Aisha, to prepare yourself and to make a good differential diagnosis, and to make a brain map for the case as we discussed: introduction, focus history, focus examination, and replying the patient concern. I think we have like 4 candidates online, so we can open the camera for them. Can you see us? Online, can you see us? That's all right. Now I'll represent the candidate. I'm Mrs. Leonard. Start.
Hello, my name is Aisha, I'm one of the doctors. Can I check your name, please?
Yes, I'm Mrs. Leonard.
Can I check what's your date of birth?
Yeah, it's 4th of May, 19, it would be like that. 80.
Okay. So is it okay? I just want to speak to you about what's brought you in today. Is that okay?
Yes, doctor.
Okay, so what's brought you in today?
Yes, doctor. I've been complaining of chest pain for the last 5 days, doctor.
Okay. And can you tell me how did the pain start?
It started suddenly 5 days ago.
Okay. And what were you doing at the time?
I was at first, doctor. I was watching TV.
Okay, and you said it came on suddenly.
Yeah, that's right.
Okay. And has it been continuous since then, or has it been coming and going?
It's intermittent, doctor, coming on and off.
Have you noticed anything that makes it worse or better?
Like what, doctor?
So, for example, when you're walking, does that make it worse?
I'm not sure, doctor, but I think I have it even at rest.
Okay. And what if you lie flat or sit up? Does that make it worse?
No, doctor.
Okay. And when the pain came on, whereabouts in your chest was it?
Sorry?
Whereabouts in the chest was it?
What about?
Where was it? In your chest?
In the center of my chest, doctor, yeah.
And did it spread anywhere else?
No, just the center of my chest, doctor.
Okay. Did it go to your arms or neck? Or...
No.
If you take a deep breath in, does that make the pain worse?
That's right, doctor. Deep breathing make it worse.
Okay. And did you have any palpitations?
No.
Okay. Any shortness of breath?
Yes, doctor.
Okay. And is it shortness of breath just sitting down or only when you're walking?
Oh, I think it's getting worse with movement, with exertion more.
Okay. And how far are you able to walk normally?
Could be for 100 yards, doctor.
Okay. And how far can you normally walk before this pain started?
I didn't feel any short suppress with any type of exertion, doctor.
Okay. And you could walk
For long distance without any short suppress.
Okay. That's fine. Okay. And have you ever had any pain like this before?
No, this is my first time, doctor.
Have you tried to take any pain relief from it?
I tried paracetamol, but doesn't help so much.
And do you have any medical problems that you're aware of?
No, doctor.
Are you not on any medication for it?
I'm just in the oral contraceptive pills, doctor.
Okay. And how long have you been taking them?
For the last 6 months.
6 months. Okay.
Yeah.
And is it a combined one?
Combined one, that's right.
Okay. Have you been on any long distance journeys recently?
No.
And what do you do for work?
I'm a secretary, doctor.
What, sorry?
Secretary.
Oh, secretary, okay. And with your work, do you have long periods of time sitting at the desk or?
No, doctor, I'm active most of the time.
Okay, that's fine. Okay. And is there anything in particular that you're concerned about?
Examination first, or this person will be the last step of the resume.
Okay, that's fine. Right, so just a few other questions. Do you have any family history of any health problems that you're aware of?
Yeah, doctor, I have my sister. She had history of blood clot before.
Okay, she had blood clot. And where did she have her blood
Yeah. In your legs.
clot? In her legs. Okay, and have you noticed any swelling in your legs at all?
No.
And no pain or redness?
No.
Okay, that's fine. And are you allergic to anything?
No, doctor.
Okay, so routine questions we ask everyone. Do you smoke at all?
No, doctor.
And do you drink alcohol?
No.
Alright. So if it's okay with you, I'm just going to examine you. So I just want to have a feel of your pulse. If that's okay, and have a listen to your chest.
Of course. Yeah. So what the first thing to do?
So first we want to have a feel of your pulse.
The pulse is the one.
That's regular. And you want to listen to the chest pulse.
Mid-clavicular line, correct. The chest examination is clear biologically.
And then I want to have a look at the legs to check.
There is no swelling, there is no undercuts in both the sides of prostate.
For examination, that would be the main examination.
Still helpful on the side.
Okay. Is there anything in particular that you're concerned about?
Yes, doctor. Is it heart attack, doctor?
Okay, so from what you're describing, it doesn't sound like a heart attack. But before we can say for sure, there's some tests that we need to do. What I'm more concerned about this being a blood clot, because you're on a contraceptive pill, and that can increase your risk of having blood clots. So what I would want to do is do some more tests. And so we'll do some blood tests and a chest X-ray, and then depending on what that shows, we can then do more other scans and investigations.
Okay, look, I'm going to be admitted, Doctor, for that.
So I think we'll just check your observations, just check your oxygen levels and your blood pressure and heart rate. If they're stable, then we'll take the blood test, just wait for the results of the bloods to come back. If the blood tests are fine, we can send you home with, depending on what the bloods show, we can send you home today as long as everything's stable. And if you need another scan, we can arrange that to be done as outpatient. We can arrange for you to come back tomorrow. But if the bloods are concerning or if you're needing oxygen, then we will have to keep you in hospital.
Is it a serious condition, Doctor?
So it is serious, but we know the diagnosis and confirm it once you're treated. Once you're started on the treatment, then that will get on top of it. You will need to stop the contraceptive pill. So I would recommend that you speak to your GP about a different type of contraceptives, and then you can.
And for how long I'll be on blood thinner?
Okay, so if it does confirm that you have got a blood clot, because we think the contraceptive pill would have been what caused it, so it will be for 3 months, and then we'll review. We'll ask the GP to review in 3 months just to make sure there's nothing else that's concerning. And then if there's nothing else that's done with you to stop the pill, you can stop anticoagulation as well. Do you have any other questions?
No, thank you, Doctor. Thanks a lot. Oh, 7 minutes, still have 1 minute more. So, discussion with the examiner. What's your clinical finding here?
So the study has, which describes a 5-day history of periodic chest pain that started suddenly 5 days ago. Symptoms are present at rest and on exertion. It's limited her mobility. She can only have 100 yards exercise tolerance. She was recently started on a contraceptive pill, and she has a family history of previous drugs as well. So my top differential would be to rule out a PE, and most likely we need a CTPA to rule out any signs of vibration.
So what investigation are going to ask for the patient?
So initially I would want to do a set of observations and then arrange blood tests, so that we want full blood count, urine CRP, just to rule out infection, and also do a D-dimer. If the D-dimer is positive, I would then want to do a CTPA, and I also want to do an echo to rule out signs of Sadek, right ventricular strain.
What is the role of D-dimer in diagnosis of PE?
So D-dimer can be raised in other conditions other than PE, but if the D-dimer is normal, then it's an indication that PE is a less likely diagnosis.
And what risk stratification score you know about PE?
Causes.
Risk stratification score.
Oh, score. So there's the well score that we can do, and if the well score is above 4, then you could.
What if the probability of PE is low according to this score? What does it step to do?
So we could arrange a ultrasound Doppler first, but given the symptoms on the presentation here, it's more likely to be a PE. But no well score doesn't mean there isn't PE.
What if the patient is shocked? What the first investigation to be done to diagnose PE?
So if the patient's in shock, you want to do a CTPA. If the patient
would you like to go or CTPA if the patient is shocked? No alternative investigation?
So you stabilize the patient first. You could do an echo, a bedside echo at the time, and see if there's anything obvious in that, any ECG as well.
What height suggests an echo? Because the height suggests PE.
So the right ventricle might be dilated, and you have a IVC would be you'd have reflux go into the IVC as well.
Thank you, Doctor. Thank you, Dr. Aisha. Okay. So now we will do open discussion about what could be missed from Aisha here. If anyone has any comment or want to add something which could be missed from Aisha. Nothing. She did it perfectly. Okay. Do you know restaurant? Do you know?
I think it was very good. You managed to reach the diagnosis then. You were very calm and and you manage the patient concerns. I would just say in the history taking, if you have a lot of time, you missed a little bit of associated symptoms like cough fever.
Coughing up blood.
Yeah. So cough fever, and then the legs swelling jaw were prompted. He said the assistant had that was something that you should actively ask. And then the smoking, alcohol, illicit drugs.
Social history.
Illicit drugs that should be asked.
She asked about drug history, actually. Yes. Right.
And then you asked, he said that it affected his life because he's not able to walk far.
Yeah.
Has it affected work?
Yeah, social history is very important, actually, and to sort out your problem in social history. I mean, we can give you like a sick leave or something, until you are completely fit to go back to work. These things are very, very important, actually, in business exam. All right.
And then the investigation, I think, that
ECG, yeah. Just X-ray. All right. Okay, we can explore together what Aisha missed. She did it very well, actually, but just we can focus on things that she missed just to be perfect. So first of all, you have to put a very good differential diagnosis list in your mind for chest pain in the exam. We have a long list of differential diagnosis, but we have to focus on the most common differential diagnosis. First of all is cardiac reason, cardiac causes. First of them is ACS, pericarditis, myocarditis, endocarditis, and aortic dissection. Second one is pulmonary causes, including pleurisy, pneumonia, pneumothorax, and pulmonary edema. Third one, vascular causes like pulmonary embolism, GERD, as GIT causes, GERD, musculoskeletal, and herpes zoster. These are the most common, differential diagnosis list of coming in the exam. In the exam, actually, the most common cases are PE, ACS, and aortic dissection. It's never they bring GERD as the first differential of chest pain in the exam. Never they bring it as musculoskeletal cause in the top of the differential diagnosis. Focus history, as we mentioned before, focus history, you have to make a very good analysis of the complaint. So chest pain, onset, course, duration, progression, persisting factor, improving factor, associated symptoms. And for any pain at all, you have to ask about the site of the pain, character of the pain, radiation of the pain, intensity of the pain, and so onset, when this chest pain started exactly, suddenly or gradually, is it increasing, decreasing, or the same, coming on and off all the time with you? Did you notice anything that worsened the pain? Like you have to mention the triggering factor, like exertion or moving around, or did you notice anything improving the pain, like rest or any painkillers? Okay, where is the site of the pain exactly in your chest? And what is the character of the pain? Is it stabbing pain, char pain, the leaking pain? This is the character of the pain. Radiation, does it radiate to anywhere else, like your jaw, your neck, your back? This will narrow your differential diagnosis range. Intensity of the pain, how much do you give this pain from 0 to 10? Okay, like that, associated symptoms like shortness of breath, cough, coughing up blood, phlegm, fever. Yeah. Like that, I finish analysis of the complaint. Number 2 is systemic review of the differential diagnosis list. Number 1 is cardiac symptoms. For any cardiac, cause like ACS, pericarditis, myocarditis, or aortic dissection. So you have to ask about any history of racing of heartbeats, shortness of breath. We asked about it before in associated symptoms. Any history of shortness of breath, and if there's shortness of breath, is it on laying at rest or with exertion? And if with exertion, how many yards the patient can walk to develop shortness of breath? Any history of high lipid profile or any family history of heart problem, to ask about hereditary causes or hereditary hypercholesterolemia or hypertriglyceridemia, for example. Pulmonary symptoms, any history of fever, cough, coughing up blood, phlegm, noisy chest, and we asked about them already on the associated symptoms. It's very important actually to ask about risk factor of PE. I think Aisha asked about most of them already. If there is any history of long journey in the last couple of weeks, if there is history of immobility for the last couple of weeks, if the patient is on any medication which can induce PE like oral contraceptive pills, if there is any history of here antiphospholipid syndrome, any history of miscarriage, for example, the patient was, and this patient has miscarriage by the way 2 times, which can raise the suspicion of antiphospholipid syndrome as a cause of PE for this patient. Any history of miscarriage, and if the patient is receiving or oral contraceptive pills. SLE symptoms. Why to ask about SLE symptoms, especially in young female patients with PE? Because SLE could be associated with secondary antiphospholipid syndrome. So we can ask about history of following of here, skin rash on the face, or joint pain, or mouth ulcers. Hereditary thrombophilia. So we can ask about family history of black blood before or similar condition, because some cases could be hereditary thrombophilia could be associated with autosomal dominant predisposition of black blood. GERD, any acid brush sensation. Do you think that the pain is increased after eating, which can worsen the pain? For herpes zoster, any skin rash. So like that, we finished and we asked about all the differential diagnosed list of the case. Now, social history. Can I ask what you do for living? How much your symptoms affect your job and usual daily activities? And if it's affecting, I'm sorry for that, I can refer you to a social worker to sort out this problem for you, or maybe to give you a sick leave during these days, or until you get better. And who do you live with at home? Who is supporting you at home? Are you financially supported? Do you smoke? Do you drink alcohol? The 4 fixed question for social history for every case. Medical history. Do you have any long-standing disease like diabetes, hypertension, high blood pressure? Drug history. Are you regular in medication or over-the-counter medication or recreational drugs? Like that, we finish the history. After finishing the history, don't ask about the concern. You have to continue your station to do focus examination of the patient. The concern is the last step in the case, because the concern, you are going to give the possible diagnosis and what you are going to do. You cannot do that without examination, right? So examination, what HMS here is very important. The first of all, in any acutely ill patient in station 5, you have to tell the examiner, I would like to do 3 things. I would like to follow ABC protocol for this patient. I'd like to see the observation chart of the patient. I'd like to put the patient under close monitoring. Why? Because such patient may be critically ill, maybe shocked, maybe hypotensive, right? So to tell the examiner that you are a safe doctor, you have to tell the examiner before touching the patient, any critically ill patient or acutely ill patient, these 3 things. To follow ABC protocol, to see the observation chart, and to put the patient under close monitoring. Like that, you'll impress the examiner so much and he will consider you a safe doctor. If you don't do that, he will consider you unsafe doctor, because you are proceeding to examine the patient without examining the blood pressure, examining the observation chart, without ensuring that the patient is hemodynamically stable, right? This is PE, and PE in some cases can be associated with hemodynamic instability, isn't it? It's the same for upper GI bleeding, for example. You have to follow the same protocol. Before examining the patient, tell the examiner that I'd like to do 3 things. I'd like to follow the ABCD protocol. I'd like to see the observation chart of the patient. I'd like to put the patient under close monitoring. Then you can examine, like Aisha did from the beginning. I examined the pulse for any complication or any pulse problem as a complication or a consequence of PE. So sinus tachycardia or atrial fibrillation, for example. Then you will examine the face of the patient. This patient is young female patient, so there is possibility that she might have SLE. So you can examine the hair for any following of hair, the face for any malar rash formation of SLE, the mouth for any mouth ulcer of SLE, right? Then to go down to the chest, to examine the chest for don't do full examination of the chest, just auscultation of the mid-clavicular line bilaterally to check for any crackles, any wheezes, or any added sounds at all. Then you will go down to examine the lower limb for lower limb edema or swelling or any significant difference in the size. And you can even tell the examiner, I would like to check the mid-conference of the mid-leg bilaterally, just to tell the examiner you would like to check if there is any difference in the conference and you are checking or for DVT, for example. This is a focused examination. The most important here in any acutely ill patient, don't touch the patient before ensuring that he's hemodynamically stable and before telling the examiner the three things we mentioned about hemodynamic stability of the patient, ABC protocol, observation chart of the patient, and put the patient under close monitoring. This is in the case of acute ill patient, upper GI bleeding, chest pain, shortness of breath. What else we have as acute ill patients can come in the exam? Bronchial asthma exacerbation, whatever the case. Concerns. Replying the concern should be focused, concise, informative, and to the point. Don't talk a lot. Tell the patient what you know. Don't inform the patient information you're not sure about. So replying the concern should be to the point, targeted, and concise and informative at the same time. What it could be, doctor? Could it be heart attack, doctor? Yeah, I agree with Aisha for her reply that heart attack is less likely in your condition, but you cannot say this is not heart attack. Okay, so you have to elect your words. Heart attack is less likely in your condition. Most probably you have a blood clot in your lung. Okay, so what we have to do now, you explain the diagnosis. You have to explain what the next step. So now what we have to do is to put you under close monitoring and to run some blood test and the scan of your lung to confirm our diagnosis. And if confirmed, the management plan. You have to tell the patient what could be the diagnosis, what you are going to do, and what the management plan, and replying the concern. So if the diagnosis is confirmed, we are going to put you on a blood thinner for some time, maybe for weeks, sorry, not for weeks, for months or maybe forever, according to the underlying cause. Of course, if it is provoked or unprovoked, but you don't have to go into these, suffocated information with the patient. Okay. Is it serious condition, doctor? Yeah, like Aisha replied, it could be serious if untreated, but luckily, if we diagnose you, you will be diagnosed in the proper time and will start treatment, and the risk will be low in your condition. For how long I'll be on blood thinner, doctor? I don't prefer for yourself because you are in the exam is SHO, so you cannot decide for how long to do it. The decision of a senior doctor, right? So you can reply it openly, like the duration of blood thinner will be decided by a senior doctor according to the underlying cause of your blood clot. It could be for a few months, it could be forever, according to the underlying cause of your blood clot. I agree with Aisha that it seems to be provoked DVT or PE, sorry, because of oral contraceptive pills, and at that time it could be from 3 to 6 months. But to be professional and to show to the examiner that you are a safe doctor, this decision will be taken by a senior doctor according to the underlying cause of your blood clot. Interpretation of clinical finding. What's your clinical finding here? Actually, interpretation of clinical finding is very important, and it is one of the skills of the exam, identifying physical signs. And Aisha, when he's asking you what's your clinical finding here, he means that clinical finding on examination, the signs, not the symptoms. Okay, it's identify clinical signs. So the first of all, you have to say that this patient is hemodynamically stable. Yeah, you ensure that he's hemodynamic, because if you ask it the examiner what's the observation chart of the patient, will tell you blood pressure is well maintained and saturation as well. They will tell you about that the patient is hemodynamically stable. So the interpretation, this patient is hemodynamically stable, or this lady is hemodynamically stable. Pulse examination, the pulse is regular, equal 70 per minute, and no special character. Um, and on auscultation, there is no equal air entry, there is no wheezes, no crackles. Even you have to mention the negative points, the important negative data or signs of the patient. Pulmonary examination, there is clear lung fills bilaterally equal, and there is no crackles or wheezes. Lower limb, there is no evidence of lower limb edema or size difference or difference in size. Like that, you interpreted all the important positive and negative data of the patient. Okay. Discussion with the examiner. What's your diagnosis? My first differential diagnosis here is PE. Okay. In terms of, you can mention the positive in terms of pleuritic chest pain and the history of oral contraceptive pills and family history of blood clot before. And we can think about hereditary condition, hereditary thrombophilia or antiphospholipid syndrome as underlying cause. Second differential here is this patient has history, family history. Her dad died because of heart attack, because of at the age of 55 years old. So we can put as a second differential diagnosis. Third differential diagnosis could be bilirubin. So it is not just definitive diagnosis. You cannot say only one differential, because this will decrease your marks of differential diagnosis clinical skill. This is a case of differential diagnosis, not a case of definitive diagnosis. You cannot confirm this is PE. You have to put differential diagnosis list, but you have to give just 2 or 3 differential diagnoses which are relevant to the case. Don't put only one differential. Don't put a lot of differential diagnoses. This will decrease your marks. But just 2 or 3 differential diagnoses relevant to the case, and you can mention what again is the second or the third differential diagnosis. What investigation you are going to do? You be organized in your investigation as well. So the first what investigation, the first one to ask for, apart from basic investigation like FBC, UNAs, and CRP, chest X-ray, specific investigation in the form of, like you mentioned, ECG, chest X-ray, troponin level, and of course D-dimer. D-dimer is just asked in a case of low probability of PE. In high probability of PE, you have to proceed directly to CTPA. So what is the importance of D-dimer in a case of PE? D-dimer has no rule in high probability of PE. Just have is a good negative predictor in a case of low probability of PE. So we are using it only in a case of low probability of PE. If it is low, it excludes PE. If it is high, proceed for CTPA. Yeah, thank you. This is this is a case which is very common in exam station 5. Chest pain. Sometimes they can bring chest pain like pain in such case. Sometimes they can bring it as ACS. Sometimes they can bring it as aortic dissection. And in most of these cases, all of them, they just bring you a surrogate, not a patient. One of the nurses, maybe one of the HCA, and you'll not find any clinical finding with the patient if it's a case of PE. As I told you, exam is not a matter of knowledge. It's a matter of performance, how you are praising the examiner, how you are giving the examiner what you want. Everyone can, from the history, can suspect, or from even the scenario, can suspect this is a PE because of the age of the patient, young age, female patient. So he can suspect this PE before going inside. But how to act, how to do this short film in a good way to impress the examiner, this is the issue, and this is the check of the exam. So this is one of the example of station 5. Next time on Friday, we are going to present a case of communication skills, breaking bad news, which is very common in the exam. If you have any question about this case or about station 5 or PACES generally, you are welcome to ask. Any question at all? Okay.
Actually, one question. Before when we go in, are you able to have like this paper to write down?
Yeah, of course.
There is-
Yeah, you are provided with a blank paper and with two cases and 5 minutes to write what you want. But of course, you are not allowed in the exam to read from the paper. You know, you cannot read from the paper and ask the patient because you don't have time. Actually, just 10 minutes. You know.
When you're presenting, can you glance down just see that you covered everything?
When you are presenting, you don't have time to write down. You know what's your finding. You don't have time. You know, you have to put it in your mind. You have to memorize it in your mind. That's why practice is a cornerstone to pass PACES. Because when you are practicing a lot, you would be used to it, and you'll be more fluent and know how to present the key because you presented it many times before. You know. I think you have exam on June. So like we have how many, like 6 weeks maybe, 6 weeks. So we can arrange for 2 times weekly. Okay, every time we can have different case. One case of station 5, one case of history taking, and one case of communication skills. Of course, it's difficult to have clinical cases. We need a case. But if you have any clinical case in our ward, I'm more than happy to do it together, like simulated exam cases, right? Yeah. Also, thank you for attending, and kindly don't forget about feedback. I'll be grateful. Yeah, thanks a lot. Jirhan, you didn't try the feedback yet.
Sorry.
The feedback. Okay, don't forget about it, please. Yeah, thank you all, and see you later.